So here's one of the things we talk about. So these are terms you need to know. Onset. When does a drug have its onset? I pop a pill at a party, a little blue pill. When's it going to kick in? That's onset, okay? And whether it's therapeutic response or not, I guess I'll have to wait and see. Right? So it's not necessarily when your drug's absorbed or metabolized, it's when does it start to have a therapeutic response on whatever the condition you're trying to deal with. When does it lower your blood pressure? When does it start to control your pain? When does it reduce your temperature? Okay? Therapeutic. Peak is how long it takes for a drug to meet its maximum therapeutic range, therapeutic response. I take drug A. When is it going to reach its maximum, the most effective it can be? When's it going to peak? And you'll talk about this when you get more advanced in your nursing practice with antibiotics all the time. They'll start looking at doing peaks and troughs and measuring levels of drugs. Okay? And that's probably why clinical instructors are way more focused on like antibiotics timing and things like that. Certain medications, you know that this is so critical, maintaining a peak therapeutic level. Duration, how long can this drug have a therapeutic response? You look at illegal narcotics, for example, the ones that are popular on the street are the ones that have really quick onset, right? Really quick peak. But conversely, the drug dealers make sure that they have a very short duration. No drug dealer is going to be selling you a sustained release form of heroin because it's not in their business to have you having it once a day or a patch for 3 days, right? That's what we do in nursing. We come up with better ways, but it's not in their market. So trough, I won't make you write this, but it refers to the lowest level of the med concentration in the body. And so some medications will measure when the peak and the trough is. When are they at their highest effect? When are they at their lowest effect? Okay? Peak and trough, you'll hear those terms, and you'll see them do blood work. Patients on gentamicin, for example, toxic on the kidneys. So we do peaks and troughs to see. Might not make sense to you where you are clinically. Until you see some of these drugs in use, it sometimes doesn't make sense. Okay, so quick review. What's distribution? So can you give me some examples of decreased perfusion? Who would have decreased perfusion? Geriatric patients might, but think of blood flow. This is perfusion to the body. So what conditions did I give you that might cause decreased perfusion? Pardon? A diabetic could, yeah, because of sort of damage to the capillaries. Yeah, you could see that. Who else did I talk to? People that have vascular problems, people that have poor cardiac output have poor perfusion, right? People that are cold, very cold, hypothermia would have poor perfusion.
What about people that are obese?
I don't know if it would do so much with perfusion. It might. It depends where the medication has to get to, I guess. I don't know if that would so much affect perfusion. But if it was a fat-soluble medication, that would be a concern. So what's the blood-brain barrier? What's that got to do with distribution? We're talking about drugs traveling through your body. Why do I care about the blood-brain barrier?
There's only smaller drugs.
And very few. The brain was never designed for drugs to get into it. It's designed to keep toxic stuff. You don't want bacteria floating around in your blood and going into your brain, right? That's a bad thing. And so we have a blood-brain barrier. But on the other side, for medications, it's concerned. What about the placenta? What are we worried about placenta with distribution? Yeah, and some drugs do cross, right? And that's what we know. Some don't, some do. So that's what it's got to do with distribution. The most abundant protein is in the body? Albumin, right? Floating around your body. Unbelievably incredible. So if it's low, what's going to happen? More free drugs. Right? So toxicity, more effects, over-sedation, right? We know drugs are bound. So if warfarin's 99% bound and you have somebody who's got very low albumin levels and I give you warfarin, oh, guess what? Your INR is probably going to spike and you might start to bleed out, right? What's the difference between bound and unbound? And bound to protein, what does that mean? What drug is important? What are we worried about? What one is going to be therapeutic? The bound one or the unbound? The unbound one, the free drug. The free drug. I'm floating around free and I can do things. I'm bound, this sucks. Right? So, what's metabolism? Come on, guys, we just did it. Break down with drugs. Okay, what our body does to the drugs. Okay, mostly occurs where? Okay, what is pharmacogenetics? Give me an example. I gave you guys one example. So if I were to test you, what would be an example you'd give me?
When you don't have the correct enzyme to properly metabolize.
Give me an example. What one did I give you? You don't have to give me the enzyme name. Codeine. Classic example. So this is a future that's coming. Okay, pharmacogenomics. What's first pass effect? Yeah. For good or for bad, right? What drugs will we be more worried about first pass effect? How though? Like what type of formulation? How do we take it that we're more worried about first pass? Peel. So always think that way. What gets most affected by peel? Yes, other routes will get affected because blood ultimately travels medications to the liver, right? But that's right. What's analgesic equivalency? Big word. Equivalent amount between, versus PO. Okay, and there is wonderful pain. If you go into palliative stuff, there's wonderful little cards that are made for palliative care to really look at this. What dose should I be putting a patient on? And so when in pharmacy, if I'm dealing with a complex patient with pain, I'll often look at how much drug do they use in 24 hours. IV. How much drug in 24 hours did I give them by IV? I'll call pharmacy, and pharmacy will then figure out how much morphine PO should I give them, or how much of a long-acting formulation, or how much of a fentanyl patch should I give them. That's all about analgesic equivalency. It's got a lot to do with metabolism.
So it's equivalency in the same drug and a different drug?
Yes, and also equivalency between, they talk about different drugs too. They talk about, but yes, classically it's between the same drug, different route, PO versus IM. What's excretion? Peeing out a drug. Getting the piss out of your body, right? You want to get rid of that drug. Right? That's what the drug tests we do, right? So what's half-life? Yeah. So at what point will half of your drug be excreted?